My name is Catherine Hayes. I'm the Director of Health Policy here at BPC. I'd like to welcome all of you to our first public event on the integration of clinical and mental health services. We're very fortunate today to have a great panel as well as a few special guests, one being Ben Miller, who is the Chief Strategy Officer for Wellbeing Trust, and very near and dear to our hearts, Nella Domenici, who is the daughter of the late Senator Pete Domenici. And for those of you who knew him, he was a tremendous advocate of mental health in the Senate and after he came to be a leader at the Bipartisan Policy Center. And we really miss seeing Senator Pete around here every day. But with that, I would like to introduce Ben Miller, and then Nella, if you will follow him for remarks after that, and then we will welcome a panel to the stage and get going today. Thank you so much.
Good morning, everybody. So my name is Ben Miller. I work for the Wellbeing Trust. We are a national foundation committed to advancing the mental, social, spiritual health of the nation. And I want to start my remarks briefly with just a question. And I want you to think about this question because it actually will have a pretty significant impact on the discussion that you hear today. If you were in charge of redesigning healthcare, what would it look like and how would you ensure that mental health was a part of it? Yeah, easy question, right? Just think on that for a second, because what we in essence are doing is trying to figure out new strategies for a new paradigm of health. The construct of health has been totally insufficient when we tease apart mental from physical and we talk about things as discrete categories instead of how people actually present, which is as a person who has health. One person every 4 minutes dies in this country from drug, alcohol, or suicide. One person every 4 minutes. 142,000 lives last year. My advisory board chair says that once you realize that something is not working, it is unethical to continue as if it is. I think we have an ethical, if not a moral dilemma on our hands, my friends. It's an issue of justice. It's an issue of race. It's an issue of equity. It's an issue that actually is much bigger than some of the things that we actually give it credit for. But rest assured, we will get there. It's going to require all of us, each of us in this room, those of you that are in this room that represent various organizations or have leadership positions, it's on you to help us figure out how we can transform health to make sure that we get the mental health and substance use piece right. If we don't do this, unfortunately, I think we might continue to have wonderful panels like this for the foreseeable future. And as much as I love coming to events like this, guys, I think we've got to fix this now. So let me take you back to 1957 just for a second. 1957, there was a report released called the Folsom Report, and it highlighted a couple of things at once. One, it highlighted that many of the solutions that we're trying to solve are actually already in community. That community has risen up, held hands, and said, here's the things that we know work for us. That's number one. Number two, the other thing that the Folsom Report highlighted was that it's not just about health care. Now, that's easy to say in 2018, not just about health care, but truly, folks, we've got to think of ways that we can integrate the mental, the social, the spiritual, all of that together. That's why we do as a foundation what we do, because we understand that it's much more complex than just simply creating another clinic or another bed or another floor to your hospital. That health is the foundation for achievement, and if we're really going to truly try and help people achieve the goals that they have for their life, we have to fundamentally rethink that construct of health. So thank you so much for being here. Thanks for being a part of our dialogue today, and I will turn it over to Nella.
Good morning, and thank you all for coming. I thought, I just left a company where every time I gave a presentation, you had to go backwards before you went forward. And so I thought I would do that a little bit here at sort of a personal level and go backwards to 1975 when my family found out that my sister was seriously mentally ill. And that's when my father and my mother really began their journey on mental illness. And also, at that point, I was about 25, and I spent the next 10 years of my life very intensely involved in parallel with my parents on a multitude of mental illness-related activities. So my historical vantage point from 1975 actually was, it was unacademic, it was very hands-on, but it was sort of very, very real at the same time. And so back then in 1975, when we found out that my sister was mentally ill, my parents sat us all down in a room and they told us, this is our cause, we're going to embrace it publicly. And it's not usually embraced publicly, but we are going to use our brand to drive this cause forward, and we're not only going to help our sister, we're going to help the country and maybe the world. But what I remember very, very clearly in 1975 was that the stigma around mental health was horrible. It's incomparable to what it is today. It was so taboo and so secretive and so humiliating and so embarrassing. I also remember very clearly there was just too little money in research being spent. I remember I used to drive with my dad to work sometimes, and he would talk about NIMH and how they don't have enough funding for this and how he was going to go fight for it, and he'd come home and say, I'm going to get it. And I remember hosting events with NARSAD, the National Alliance on Research on Schizophrenia and Depression. I was on the board, and we hosted many events trying to raise money for research. And we were able to pull some of the big pharma companies in and some of the big device companies in, but it was a huge uphill battle. Similarly, I remember at a personal level with my own sister that the diagnostics around what does she have were very, very gray and very vague. And the treatments were blunt, and many of the side effects for the treatments were bigger than the mental illness problem in and of itself. And there was a randomness to it, a trial and error, a serendipity to it that's almost inconceivable in modern healthcare. And I remember my parents worried about the cost at their level for them, for us. And I remember my father saying, this is an illness that bankrupts families. I can remember them coming home and saying, oh my gosh, it costs $20,000 a month for this one and $9,000 a month for this one and $500 just for a 45-minute appointment, even if you're 20 minutes late. And they were just torn by that, not only for themselves, but thinking about all the families that they knew could really suffer financial crisis because of the illness of one child in that family. So I constantly kind of look at those 5 threads, right? Stigma, research, diagnostics, treatments, and cost, and think, how are those 5 boulders being pushed up a hill? How are we getting better in all 5 of those areas? And when I step back today, obviously the stigma is much, much reduced. We have people like Michael Phelps talking about depression. There's posters of him everywhere. We have people like my father and mother who are welcome and happy to be open about it. The research is much, much higher from both the private sector and the public sector and the nonprofit sectors, a theme I want to keep emphasizing. Diagnostics are still vague, honestly. There's a lot more precision, but it's nothing that we shouldn't be settled with the level of precision. It's still very much trial and error. And the range of treatments has bloomed and blossomed, but the availability of those treatments is still very expensive and still not accessible to many, many people. And the cost is still high, but we do have insurance coverage now that is arguably equal for people with mental illness as well as physical illnesses. And that we can attribute to a very successful bipartisan effort by Senator Wellstone, Senator Kennedy, and my father. And I use that more as an example of a major thrust where a boulder got pushed way up a hill because people from different parties and different perspectives locked elbows and said, this isn't a partisan issue, this is really an American issue, and it's a global issue. But despite all the success from that terrible starting point when I got introduced to this in 1975, despite the huge success, we still have 44 million Americans every year who suffer from mental illness. 44 million. We still have 16 million people who have at least one major depressive episode per year. 18% of people in America suffer from anxiety. So these are just huge numbers. Suicide has gone up 25% in the last 15 years. It hasn't gone down. A lot of that is attributed to mental illness. The cost of mental illness continues to be huge. Numbers like $200 billion in lost productivity due to issues like depression are out there. So we've pushed these boulders up a big hill, but there's still a long, long ways to go. And as we look ahead, I think one of the most important things is that we try to unite the Republicans and the Democrats and make sure this is not a political cause, a political problem or a political solution, and that we inspire the for-profit world and the innovators in the technology sector to come up with new and radically different and radically more affordable solutions, and that we work hard with the public sector to make sure there's funding, and that we continue to have our nonprofit sector with incredible, incredible organizations like NAMI fight stigma and help at the real grassroots community level, help in the community way that we just heard about earlier. So with that sort of positive and negative tone, we've come so far, but we have so far to go. I thank you all for coming, and I welcome you for offering your ideas and your energy and your openness.
Thank you, Ben and Nella. At this time, I'd like to invite our panel to come forward. Our panel will be moderated by Marilyn Serafini, who is a consultant to the Bipartisan Policy Center. You have all of our panelists' bios in your packet, so I'd encourage you to read those. And with that, Marilyn, I'll hand it over to you.
Good. Very good, Catherine. Welcome to everybody here. We're really excited at the BPC to be working on this integration issue. We think this is an area where there's really great potential for bipartisan action. We're already planning a second event for November where we are planning to release a set of policy options, so stay tuned for that. So we're hoping that we can come up with some policy options that will help policymakers to create a favorable environment for integration. So our goal for today is to examine both the promises and the challenges of integration. We're fortunate to have with us a very knowledgeable group of panelists. To my immediate left is John Arbach. He's President and CEO of Trust for America's Health. Next is Tom Betlach, Director of Arizona Healthcare Cost Containment System, which is Arizona's Medicaid program. Patrick Gordon, Vice President of Rocky Mountain Health Plans. Angela Kimball, she's National Director of Advocacy and Public Policy at the National Alliance on Mental Illness. And Jill Bonenkamp. Jill is Assistant Professor for the Center for School Mental Health, Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. So I'm going to be facilitating the discussion today. We're going to spend about 45 minutes discussion among us here up on the stage, and then we're going to open it up and give you all the opportunity to ask some questions. So we're going to start with the broad problem, then very quickly move into progress on integration, what we have seen so far, where we have gone, and the challenges that are holding us back. I assume that a lot of that's going to run together because as we start talking about what we've done and what you all on the stage have accomplished, we're just naturally going to get into what are the challenges, what are the barriers, and we'll finally wrap up with what is it that we can do both at the federal and the state level to create an environment where we are choosing to incentivize integration. So let's start with what we're trying to achieve. What's our goal here? What are we talking about when we're talking about integrating physical and mental health in the first place? John, do you want to kick us off there?
Sure. I think we're talking about being able to access health care that has the potential to address all of the needs of an individual person, rather than segmenting people by body parts or conditions to different systems or different providers. So I would say a model for what we're trying to do is a full-service, one-stop shopping kind of a healthcare delivery system where you can enter in any door and receive the full range of services you need, physical, substance misuse related, mental health related, all within a relatively easy facility, ideally, or if not a facility, a system.
So why do we want to do this? Why do we need the integration?
So I'm going to build on that because Medicaid's the single largest purchaser of mental health and substance use disorder services, and what we've seen historically oftentimes is fragmentation that exists from the system design perspective. And so when you think about it, when we talk about integration, we actually talk about 3 levels of integration: the policy, the payer, and the provider. And really the policy and the payer need to support integration at the provider level. And so when we look at our journey in Arizona, it's oftentimes been pursuing different strategies to try and reduce that fragmentation. And the example that I like to use is if you go back and you look, and this type of system design exists in many states. For an individual with serious mental illness, oftentimes that individual may be working with a health plan for their physical health needs, a different health plan and providers for behavioral health needs, mental health, substance use disorder needs. Then oftentimes they're Medicare enrolled. So you have Medicare fee-for-service, a Medicare Part D plan, or a Medicare Advantage plan. So oftentimes you can have up to 5 different organizations involved: payers, providers, in the delivery of care. And that type of fragmentation just does not equate to the holistic approach that John described.
You know, from my perspective, it's interesting what you can accomplish working at the plan level, in my case, just by getting started. Just sort of taking a just do it approach to this. Integrated behavioral health is a complex topic. That's why we're all engaged here. But actually, there are significant quick wins that can be accomplished with relatively little investment or change. Certainly, the effort to get services to where people are, whether it's through primary care, through telehealth, or broader arrangements, really that's just a matter of adopting a different mindset in some cases, aligning it with work that's already well underway within the healthcare system, and working systematically to break down barriers. So with respect to primary care, there's tremendous work that's gone on over the last several years, both the provider side and the payer side, to create data-driven, team-based processes that look at the whole person. Well, we're missing the whole person if we don't account for behavioral health. What's interesting is that when we start talking about behavioral health, for some reason the conversation often takes a different turn. But if you back up and can simplify and just say, look, we're making payments for care coordination, we're making payments for quality improvement, we're making payments to integrate pharmacy in clinical sites, why not behavioral health? And you look at the cost, the relative cost of adding behavioral health in a broad network of healthcare, it's infinitesimal, and yet the impact is significant. Identifying needs, unmet needs, beginning treatment and prevention earlier, reducing the overall cost of care and cost trends, improving provider experience, improving the capacity of our system to take a larger number of patients as well as more complex patients and serve them effectively. Those are all outcomes that we've been able to achieve just by making simple changes in payment. And broad system change will take a heavy lift. It will require state, federal, local alignment, payer-provider alignment, but we can start now. And there's tremendous opportunity for patients in just making small changes.
What's the vision? I mean, what do we want in an ideal world? What do we want integration to look like? How do we want this to come together? Angela?
I was going back to the earlier question, what are we trying to achieve here? And besides the earlier intervention, and that's absolutely imperative, we need to normalize mental health care. And I'm just struck going back to my early days as a parent of somebody who had a pretty severe mental health condition. Had to drag my son literally kicking and screaming down a hall to a psychiatrist's office where he ripped apart a rather large office plan. That's because that was an alien place to go. He did not want to go somewhere that basically said something was wrong with his brain. But he was used to primary care. And even as a young adult now, he is willing to go to primary care. He is absolutely not willing to go to community mental health care. So to me, that's the fundamental goal here is we need to engage people in a way that makes it okay to have a mental health problem, makes it okay to have a substance use problem, and to get the care that people need.
I mean,
So-
the ultimate outcome you're trying to see is, there was a study done a few years ago, individuals with serious mental illness on average died 25 years younger, and oftentimes it wasn't mental health issues, it was chronic conditions and untreated conditions associated with that early mortality. And so ultimately what we're trying to do is create systems that improve outcomes for individuals, not create systems that are even difficult and complex for somebody that's been doing this for 15 years to just describe. I mean, it really goes back to part of the moral imperative that Ben described in his opening comments.
I would share what I think this looks like often on the ground. Well, I was formerly a state health commissioner in a state where the governor said to me, work on eliminating those barriers between behavioral health and primary care. And so we thought of first, well, where are the places that people are comfortable going now? And we decided to start with community health centers and treatment facilities. Because we thought, well, let's go to the community health centers where they have primary care and add behavioral health as just one more service. Let's go to the substance abuse and mental health facilities and think, how do we add primary care to them? And what we found was lots of obstacles in terms of that. Lots of rules that got in the way. It wasn't as simple as, there's a couple of extra offices in the health center, let's just have the behavioral health people start using those. There were contracting obstacles, and there were licensure obstacles, and there were physical facility obstacles. All these things that perhaps at one time had good intentions, but it really made it hard on a very practical basis to make it easy for the person who just wanted to go to wherever they felt comfortable and access the services they needed. So paying attention, I think, to those very practical things where people go already that allow them to build the services that I think is key.
So speaking of where people go already, Jill,
love
let's
to
talk
jump
about
in.
the schools.
Sure.
Especially since we've heard a couple of you now talk about the importance of early diagnosis, early intervention. So let's talk about the schools.
Sure. So I'm at the National Center for School Mental Health, and we work with schools and districts across the country in increasing and improving their school-based mental health services. We also have a partner organization that looks at school-based health services, school-based health centers. And speaking of where students, where children and families are, they're in schools, they're in communities, and this looks really practical. When we think about this, it makes sense, right? A child is at school, a parent may be at work or may have other things going on. It doesn't make a lot of sense for them to have to take time off work, come pick up their child, go to a place that may feel stigmatizing or unknown, but it really makes sense for them to be receiving services in the school. This looks a lot different when a counselor that they know or a teacher that they know says, talk and connect with this counselor. We'd love for you to sit down and problem solve with them. They can meet you in the morning when you drop your child off at school. They can connect with you at the end of the day. They can connect with your teacher. This looks really practical. And so we know that schools are just an ideal place to be able to serve students, and that this is happening across the country, that this is not a new or unique idea. Many studies show that the majority of children who receive mental health services receive those in the schools already. This is not just mental health services like individual therapy or family therapy. This includes a full continuum of mental health services. This involves early intervention, early prevention, talking about mental health, not just mental illness, but mental health with all youth across the country. This is important. This makes sense. Why are we talking about this when it's a problem? We want to be talking with all youth, with universal prevention programs around how do you promote your mental health? How do you promote your well-being? How do you interact with your peers and get along in society? I could go on for a long time about that, but I'll stop to let other folks jump in.
Well, Jill, just give us an idea. How much are we doing in the schools? Are there a few examples, or is this really a broad effort?
Yep. So we are currently engaged in a national census to really better understand just how widespread this is and what that looks like across the country. It certainly is not just a group of schools. This is a growing momentum. There has been significant federal, state, local foundation investment in this work, and we're excited to feel like we're moving towards a tipping point where this is not just happening in pockets across the country, but feeling like this is an opportunity for all students and families, and really is just such an opportunity for equity and access, and to be moving upstream of mental health concerns and really be focusing on prevention.
Right.
I would echo that just briefly. This is a particularly powerful model in rural settings. Just anecdotally, in our community, several rural and frontier settings in Colorado, the growth and ongoing demand for school-based services has increased significantly. And when paired with telehealth solutions, it can be a very powerful way of reaching kids, reaching families, and connecting services in areas that are otherwise underserved.
And I just want to add that I'm really glad you mentioned telemental health services in those settings as well, because I think while the access is wonderful and the normalization in school-based mental health settings, one of the challenges we still see is a lot of school counselors who don't really understand more serious mental health conditions. So when you're able to loop in that telemental health and some professionals who really have experience with more severe conditions, it really helps make it a more robust response that meets people's needs.
Absolutely. And when we talk about comprehensive school mental health systems, it includes school-based providers, school counselors, school psychologists, but it also includes linking with community partners and having community providers augmenting in a meaning and purposeful way those services to make sure that all of those needs can be met in the school setting.
I would add that we, at Trust for America's Health, we're working now with 15 teams, a team from each state that includes the Medicaid program, the education secretary, and often the public health department, focused specifically on the ways to bring services into schools. And in almost every one of those states, they've raised behavioral health as the #1 issue. But when they've asked us for technical assistance and support, they've often said they don't know how to do telemedicine. They don't know how to do it for a lot of reasons. One is it requires real guidance from an expert in terms of the room it should be done in, who should diagnose the child before making that arrangements. But a major issue that they raise is reimbursement, because I think the reimbursement systems are still working through. Can this be billed? A lot of our billing systems are based upon a site-specific license that you can only bill if you see someone in your office in a particular address that's been registered on your license. And so I'd say this is one of those big obstacles where it makes sense, but the practicalities of it are not as easy for everyone.
So I knew this was going to happen. We're clearly inching into what the barriers are, and that's fine. We want to spend a lot of time on that today. But before we jump into that any further, I'd like to get a better idea of the landscape. We've talked about what's happening in schools. Tom, I'd like you to talk about the landscape for Medicaid and what you're doing in Arizona, and then Patrick, I'd love to hear what you all are doing, and then we can go headfirst into barriers.
Sure. So in Arizona, we've been on a multi-year journey where we've been really looking at eliminating the carve-out and integrating in mental health and substance use disorder services into our model. And again, back to the 3 layers that I talked about. So we had a separate state agency involved in the delivery of mental health and substance use disorder services. That got merged in with the Medicaid agency. Along with that, really, I think some important resources in areas like housing, employment support services. So as a Medicaid director now, I have the ability to sit down with staff that are focused on housing issues, employment issues, and it's really great in terms of trying to leverage a variety of different resources, including Medicaid, but even beyond Medicaid. So that's sort of the policy level. And again, looking at things very holistically. regulations, and how do we address regulations that might be barriers to integration. Payment incentives. We've created incentives for organizations that want to offer physical health services in a mental health or substance use disorder or behavioral health setting to incentivize that. So we've done a lot of work in terms of policy, looking at policy holistically. Payer, integrating all the different variety of funding streams, including not Medicaid funding streams. So the SAMHSA block grants are now integrated into our payers, into our managed care organizations to go out and provide resources for individuals that may not be eligible for Medicaid, including those housing dollars, employment dollars. So really making the plans accountable for the full array of services, looking at things holistically as part of this model, and then to support providers on their journey to integration. So we've got clinics that are just doing amazing things on integration, where they've got the housing specialist next to the employment specialist, next to the psychiatrist, next to the primary care physician, working with the pharmacist. But that may not be for every provider, right? So we recognize providers are on a continuum. So we're providing resources out to providers on their journey through a targeted investment program. So just really this holistic focus on integration at 3 levels, being driven through Medicaid, but really trying to leverage all the different community resources we can. And then one final point I'll just touch on is aggregating data and sharing data where we can. So we've got partnerships with all of our counties, so we're sharing justice information. We're in the process of connecting to the homeless database, sharing that information with our managed care organizations so that they can engage the members in a real-time basis. So really looking to try to leverage so the unique aspects of Medicaid in terms of integration, because again, going back, we're the largest purchaser, so if we can do this, it really benefits everybody within the delivery system.
What kind of results are you seeing?
We're seeing some terrific results. So there was a study that was done that looked at the impact of housing, 24% reduction in cost for individuals that received some scattered housing subsidies. We're seeing increases exactly in some of the areas that we wanted to see in terms of primary care, chronic disease coordination, those types of HEDIS measures. So we're starting to see some positive outcomes, but I will tell you, this is a journey, right? These systems had this type of fragmentation for decades, and now it's breaking down those barriers. And you mentioned all the fragmentation that exists. One of them is just relationships, right? So I was in a meeting, and our largest behavioral health service provider for children's had never sat next to our Phoenix Children's Hospital CEO. And you know, there was a connection that was made that didn't exist before.
Patrick?
So I would build off a lot of that. You know, state action, really creating the policy framework in which integration can happen is critical. And you know, certainly as a managed care provider, when the structure is right and when the accountability system is set right, there's a lot that can be accomplished with a public-private partnership. I think of managed care as a framework in which you can kind of stretch the rubber band. You can do things that you might not otherwise be able to do in a traditional system. You can fine-tune relationships, fine-tune contractual tools, but ultimately we're driving at the same thing on the ground. A single point of accountability, a focus on total cost, not just segmented silos of financing, and creating integrated arrangements, so integrated leadership, having behavioral health sit alongside all of the other healthcare and community interests at the table, and having skin in the game, having a financing model that basically transcends the carve-out, right? So if savings are created anywhere in the system, particularly in behavioral health, where in mental health services, community mental health services, where there's a very high leverage opportunity, giving access to some of the shared savings and reinvestment at the community level is possible when you have integrated leadership. Data, again, it's kind of a matter of fine-tuning. States can, and the feds can do big, important things with big data, but getting that data to the right place at the right time for the right purpose, managing consent appropriately, and really capitalizing on the care coordination opportunities that are present in a community system that's well run, that's a function of really local leadership. And so from my perspective, what we're trying to do is create an overall policy framework, take advantage of public-private partnerships, build on the resources that are present in things like the community mental health system, move mental health kind of into a mainstream budget, and then kind of create a feedback loop where we give feedback on regulatory and other policy changes that could occur. There's a lot of legacy present in these systems, a lot of opportunity for reform, and just creating that dialogue where we can systematically point out barriers and knock them down. Certainly has worked well for us in our state.
So we have already through our conversation started to touch on a lot of the barriers. We've heard about technology and data sharing limits. We've heard about payment models and the difficulty in aligning payment. We've heard about barriers to telehealth. What's most important here? And let's talk about some of these barriers.
So I'd start with duals in terms of when you look at the barriers that exist between those two systems that for a long time.
So you're talking about the people
Yes,
who are on both
thank
Medicare
you.
and
Yes,
Medicaid.
right. So when you look at individuals with serious mental illness, almost 50% are enrolled in both Medicare and Medicaid, and historically those systems have not done a great job of communicating. And we've seen efforts over the last few years now where states have really tried to create models that align and create the opportunity to better coordinate care for those individuals. And so there was a study done recently on Minnesota's dual special needs program that showed over a 40% reduction in use of hospitalization, but increased use of primary care and home and community-based services. And so I think looking at continuing to build on the momentum that's already existed in the space of duals, but really pushing that forward, and particularly with models that look to address individuals with serious mental illness and really create some opportunities there.
I think we also have to mention that Medicare still does not have parity. So that at a very global level still exists. And beyond that, we have other regulations that are getting in the way, like 42 CFR Part 2, which is a regulation that is around privacy information and the sharing of that personal health information. And it's much more restrictive than HIPAA. And without that alignment between 42 CFR Part 2 and HIPAA, it's creating huge barriers for electronic health records, for health information exchanges. It's just prohibiting the appropriate sharing and the integration of care.
Right, as we see providers wanting to move towards integration, there really is not a great, robust, integrated electronic health record. Part of that is the limitations of Part 2 and the ability even then to see that data moved out into a health information exchange with the appropriate protections. But really, I mean, as we look at the ability to improve care coordination, that information, that data being able to be shared is critically important.
So talk just a little bit more about exactly what that limitation is and what that means. How harmful is that?
Well, there's an explicit omission of case management and care coordination from the revised regulation. And that has a significant chilling effect on what we would otherwise be able to do with the resources that we have. It's a targeted policy, but it has sort of a blunt instrument effect in terms of shutting down health information exchange use cases, care coordination use cases, integration use cases. I realize that that's a complex issue, but I think we're at a point where we have technology and some of the policy framework moving along where parity between HIPAA protections and what's currently permitted under 42 CFR it's time for that to happen.
I think I would also raise how complicated it is for a healthcare provider like a community health center or a treatment facility to try to change. Even when there are good efforts being made at the system level, if you're not making a whole lot of money while you're running your healthcare facility and you're trying to integrate the services, you'll find one headache after the other. When we looked at this in Massachusetts on that governor's committee I was mentioning, we found that there were 100 regulations, 100 in the state that had language which made it hard to integrate services. Sometimes it was little things that had to do with licensure of nurses or doctors and where they could bill. Sometimes it was major issues like you had to have a separate waiting room or you had to have separate electronic medical records. And so it meant that it just was too hard for the well-intentioned provider to easily solve those problems. So I think part of the problem is at a state level and in terms of state and federal rules and regulations, there really needs to be partnerships where people just sit down and figure out, how do we make it easy? How do we help people not have to go through 20 different steps and lots of applications and telephone calls and appeals in order to be able to integrate the services? And there are some, I think, good models of how to get around that. But it takes, I think, the practical application of, for the, how do we make it easy? How do we make this work so that access can be increased in a comfortable way?
I would just echo, it has always struck me that it falls to providers to navigate all of those regulations and to do the braiding of funding. That is the least efficient, most burdensome way to do this. Really, it's a responsibility of the system to do that work so that providers can do what they're there to do.
And the electronic health records don't support that flow at all. I mean, it's just a barrier.
Well, the behavioral health electronic health records have grown up around all these very arcane, oftentimes state-specific requirements.
Yeah.
They're light years behind the other EHRs, and we need to close that gap.
So it seems as though certain systems are better set up to be able to perhaps get around some of these barriers. For example, Medicaid? Is that why we're seeing some progress in Medicaid? Or?
Well, I wouldn't say we're better positioned. I would say that we clearly, we're a significant purchaser, so trying to move the needle with regards to some of those changes. And again, looking at policy more holistically, I think gives us the ability to do that. But what's interesting about Medicaid, and when you look at the national framework around the policy expertise, that sits in SAMHSA. Yet Medicaid's the purchaser oftentimes. And when I look at Arizona, SAMHSA block grants are such a small portion, yet that's where the expertise sits. That's where the knowledge in terms of fidelity rests. There's also incredibly burdensome reporting associated with those block grants that I think oftentimes negatively impacts providers wanting to participate in some of those services. And when you look at models like first episode psychosis, where you have centers of excellence being created in states, that's really oftentimes kept separate from the Medicaid program, where in Arizona, or where you have states that are aligned, you can at least target the Medicaid population towards those centers of excellence. So I think when you look at some of the federal constraints, trying to get better coordination between SAMHSA and Medicaid at the federal level would be helpful in terms of, I think, really advancing the system around integration.
And I would just build on that slightly around the financing side. We know there are interventions with tremendous evidence. ACT is a great example. ACT like PEER. What we find is that because the financing system is so fragmented and so siloed, many of those evidence-based interventions are constrained artificially. So achieving financial integration, creating a pathway for investment in things that work across the entire system is a big part of, I think, what we're talking about here. Again, there's a tremendous opportunity just building on what's present in block grant funded programs, but expanding them appropriately across the entire budget.
I think it's also important to talk about the mix of payers and the fact that a lot of kids, young adults, are on private insurance. Mm-hmm. And as long as we have a country in which people are churning in terms of their covered payer, we don't have the incentives necessarily within insurance plans to actually buy into the evidence-based practices. And I think it's remarkable that in this country, the best evidence-based interventions for people with serious mental health conditions is in the Medicaid arena. And that's because we abdicated responsibility to a public health system. And I think one of our challenges is, how do we get all payers on board into delivering the best, most effective care earlier?
How do we do that? So let's transition a little bit into...
That's a million-dollar question.
Yeah, let's transition a little bit into how we make still yet talk about additional barriers, but let's spend some time talking about how we address these barriers. And let's talk about federal versus state as well, because there are items in both at both levels.
I would share a solution that or a creative solution that we tried in Massachusetts, which was we decided it was just too much of a headache and a complicated drawn-out process to change 100 regulations. So we identified a person who had the authority from the governor to waive the regulations and make it easy for someone who wanted to provide services. People would just call her. She was a nurse. They would say, I want to add these services. She would then figure out all of the hurdles that had to be overcome, and she would systematically figure out how to waive those if, in fact, it was a plan that made sense and had high quality. And so it streamlined things completely. It did require that she could call up the Medicaid program, the mental health department, the public health department, and get their agreement that the waivers made sense. But I do think thinking creatively about how we kind of get around these barriers rather than to think of 20 different systems, each of which we hope will change in order for them to be fully integrated. So creatively getting around those problems with waivers, I think, may be an approach.
Yeah, one thing I would say is, again, no easy answer. I love the idea of a czar or czarina. But starting at the lowest common denominator, again, in our case, primary care, foundational work. There's, again, so much that can be accomplished with relatively small changes in payment and investment. Primary care is the least invested part of the healthcare system. In our case, working across coverage types, as a private payer, we recognize it to be self-defeating to segment our payment models across Medicare, Medicaid, commercial business. Most providers can't and will not segment what they do for their population. Our payment models can't do that. And so in our case, when we roll something out for a Medicaid population, there's a huge opportunity and obviously disproportionate need in Medicaid. But those reforms have been spread across our Medicare commercial business as well, our exchange and individual business. And that's really essential to get enough critical mass within a provider setting to drive change. So again, it can be done. Again, we've had the greatest flexibility at that foundational level of primary care, but there's a lot of logic in working across coverage types to drive change.
So I think one of the things we really haven't talked about is workforce as part of this and some of the challenges associated with that. So I look at a state like Arizona and the fact that Medicare has locked in graduate medical education slots at 1996 levels, yet our state has more than doubled in size since that point in time, is a real limiter for a state like Arizona. So, all of our graduate medical education slots sit in Massachusetts. So at some point in time, I think Congress really has to look at the formulas around that and maybe look at creating incentives where we see areas of need. So child psychiatrists is a definite area of need. So wouldn't it be great to have public policy making at the federal level recognize the fact that there are growth states that have areas of need that look at important services like child psychiatry?
And I would say that you have opportunity in the workforce as well. I know there's a lot of conversation that happens within comprehensive school mental health about licensure and licensure reciprocity for providing services in the schools versus providing services in the community. This looks different state by state, but that there's opportunity, that there are trained professionals that may have some barriers to providing services, and so thinking about ways to break down some of those barriers.
Huge opportunities to partner with local residency programs and community resources to grow your own workforce. And again, yes, there are gaps in certain specialties like child psychiatry, of course, but also when we're talking about integration, we're oftentimes talking about the other end of the skill spectrum and creating a culture and a workforce that's readily available as a part of the community. That's the essence of the community health worker concept. That's the essence of peer concepts. And so I think a lot of the workforce and kind of acculturation work needs to happen on the lower end of the skill mix, perhaps.
And I would say we're not even leveraging everything that's out there in the community. So there are public health systems with public health nurses who are going out to people's homes, and yet they're not delivering behavioral health services to some of the people who may need them the most. We're also not taking advantage of emergency medical technicians who are often being called to the scene because of people who have severe behavioral health conditions. We have long-acting injectable forms of antipsychotics, and we don't have the ability to deliver those in let's see, I'm losing all my thoughts right now, but in pharmacy offices, those EMTs could be delivering LAIs on the scene. There's a lot of opportunities, and we just haven't been doing it.
And on criminal transition. So you brought up the injectable point. So many people fall through the gaps on transition, discharge from criminal justice settings to the community simply because they can't get a prescription refilled or can't get access to the injectable.
And we've mentioned telehealth, but let's talk a little bit more about telehealth here. Does telehealth help with the workforce issue? Should it?
Absolutely.
Yes.
I think we're all in agreement
Yes.
there. And that is one of those normalizing things. People want to be able to pick up their phone. Everybody's on their cell phone. It's a way to interact with people. People are familiar with that, particularly young adults. And that's who we need to reach when we think about when serious mental illness manifests, 75% by age 24. That's a generation that's online. We need to be delivering services online.
So how do we break down those barriers, the telehealth barriers?
It, of course, is payment, right?
Yep.
So telehealth is a huge opportunity from a capacity standpoint. We can use our existing workforce to increase capacity and access significantly through telehealth. There has been a lot of work to break down barriers on encounter-based telehealth. So within Medicare and Medicaid, you can have patient-to-provider direct telehealth encounters reimbursed. But looking ahead, a lot of the opportunity is asynchronous, non-encounter-based, sort of an ongoing conversation, messaging. And we need a payment model that can support that. Granted, PMPM or capitated type projects can help facilitate that type of process, but we need to wrap our mind around the fact that there's a huge opportunity in non-encounter-based services, more asynchronous types of engagement.
So
And that really comes back to system design, right? Because as long as you have a carve-out, it becomes difficult to get to those types of models that really align the incentives to leverage that technology to move it forward.
So I'm going to ask each of you who wants to weigh in on this, if you could make one change at the federal or the state level to help to push integration along, what would it be?
I'll start the bidding. So you're catching me on a bad week. Can I do 1.5 or 2?
Sure.
I got to do a call out on IMD. Again,
Explain what that is.
so there is limitation on coverage in certain settings. And generally speaking, it's not a covered Medicaid benefit for adults. Through managed care, there's a 15-day grace period that's granted in the current regulations. We need greater flexibility. We don't need to be paying for unnecessary mental health placements, but we need greater flexibility. And I think that flexibility would go a long way to reducing poor outcomes, readmissions, and additional costs that states and other payers bear. Okay, now that I have my IMD piece in, I do want to call out the point we discussed earlier, which is that going all the way with revisions and reforms to the 42 CFR to explicitly permit care coordination and case management use cases is an important change.
So I think I would say create an incentive for the federal agencies to work together to solve problems and to think about things like having the same reporting systems rather than multiple reporting systems, the same a way of accessing resources that are across an agency instead of having a provider needing to figure out, well, when do I work with Medicaid, when do I work with SAMHSA, when do I work with with CDC. Solve those problems at the federal level with cross-agency coordination so that it's easier at the state level or at the provider level.
Mine would be a path towards being able to leverage Medicaid for housing for a select number of individuals. So if you look back 30 years, Medicaid went down the route of being able to leverage Medicaid for home and community-based services, and we transformed the delivery system for individuals that were institutionalized in nursing facilities. And we now spend more money on home and community-based services today than we do on nursing facilities. So I would like to see the ability for states to be able to target a small number of slots for some form of residential housing support, because we know in the data that for a small subset of our population, we can improve outcomes and reduce overall costs.
And I would say thinking about how we can make sure that we're focusing attention on prevention dollars. So that's what comes up most frequently in our school setting about services, is that they have options and have it figured out for providing mental health care services, but for doing prevention, school-wide prevention efforts, there's less understanding or opportunity for how to fund those options, and they're relatively less expensive and in the long run as well.
So before we turn to Angela, after we hear from Angela, we're going to turn to your questions. So be thinking of what you want to ask, and we'll have some roving mics that you'll speak into. Angela.
I would just like to say we'd like to build on the legacy of Senator Pete Domenici and really have true parity across all government plans, all commercial plans, every health plan out there. Unless we do that, we're not going to achieve what we want to have here.
Thank you. Okay, who has a question? Yes, and if you could please identify yourself, wait for the mic and just identify yourself and ask your question.
Sure, thank you. My name is Cheryl Phillips, Special Needs Plan Alliance, but I'm also coming here as a geriatrician, and so while I am passionate about all of the issues in a fantastic panel and all the prevention, another barrier that I think we haven't talked about is ageism. And while seniors who face mental illness, we often think of depression, dementia, those are awful enough, but serious mental illness ages, and people reach their senior years, and inpatient mental facilities won't take them because they have lots of medical problems.
Right.
The medical environment won't deal with them because they have serious mental illness, so they get housed in nursing homes, which is probably the most disastrous place. Any thoughts about how states are addressing the integration for older persons with serious mental illness, recognizing the lack of parity with Medicare and all the other complications?
So again, from my perspective, it comes back to system design and trying to reduce fragmentation and making sure that you have models and systems of care that recognize that you have to create opportunities for the managed care plans to work with providers in integrating setting to address the population. So we just went through a process of going through a competitive bid to serve members in our long-term care system, and by having behavioral health at the table helping to create those contracts, I would say there's a lot more robust infrastructure around how to address individuals with serious mental illness in our long-term care contracts than ever existed before. So we've extended a lot of the work that was done in other systems into the long-term care system around things like looking at case management support for those individuals, looking to support those individuals in the home and in the community in more robust ways, and looking at having more expertise at the managed care level to work with that population. So those were some of the steps, and there's many more that we took in this contract. But to recognize that within the long-term care population, we know that we have over 2,000 individuals with serious mental illness that aged into that population.
I would also add that as we've looked at the needs of the population of older adults, a major barrier has been social isolation. That sometimes the individuals are neither entering the primary care nor the mental health system because of transportation barriers, because of uncertainty about insurance issues, because of complicated social and economic issues. And so I think a piece of it is also thinking about how do you reach people who may not be in the system already, but may be living at home isolated and in need of services.
And I would add that from what we have seen, providers are simply not comfortable providing services to that population, regardless of whether it's elderly adults who are exhibiting mental health symptoms or, more importantly, people with serious mental health conditions who are aging. those are populations that people are not comfortable serving. They don't feel like they know how to. And when people don't know how to effectively support those individuals, they tend to point fingers towards another system and say, they're not mine, they're yours.
Okay, so a question right here.
Florence Fee, I'm Executive Director.
Microphone. Right behind you.
Thank you, Marilyn. Florence Fee, Executive Director with No Health Without Mental Health. We are a nonprofit advocacy organization. For the last 12 years, we focused on this one issue at the policy level of behavioral health integration into primary care. And, there's a lot one can say. It's, it clearly is a very complicated, complex subject. Integrated care, both integrating behavioral health care into the medical setting as well as integrating better medical care into the seriously mentally ill, especially the behavioral health sector, which is so vitally important. But I think it's a complex, multifaceted subject, and one that we can all become easily overwhelmed on. Just listen to the discussion this morning, how many areas that we've touched on. I'd like to focus on Marilyn's question about, what would be one practical, realistic thing that we could do right now, considering the multi complexity of this issue. And I would say that, as Tom has said, that, we will never have true integrated care under a fee-for-service system. And I think the value-based care delivery reform, in which accountable care organizations, patient-centered medical homes, 30-day rehospitalizations, where health systems are now being held to account for populations of patients. And these health systems are realizing that they cannot achieve their financial results without integration of behavioral health.
Yep.
So this is a very major transformation. It's coming at the same time as you have transformation of the primary care system, which is so underfunded. So I think this is one area we can look at in integrated care, to be a vital part of the value-based care delivery reform, be a vital part of the primary care transformation reform. And the final point I would make is I'm surprised no one mentioned the 2018 Milliman report, which an highly respected actuarial reform, which showed that potential cost savings, 36 to 68 billion, where we end across Medicare, Medicaid, and commercial. I think that's an important message to get across in this administration, the huge potential cost. And then finally, to underscore, we will never, until we manage behavioral health organizations and unite medical and behavioral health care delivery as well as medical and behavioral network providers and health plans that cover behavioral health as a part of medical benefits. Till we do those things, that's out there in the future as a goal. But I think for now, focusing on our place in the value-based care delivery reform. Thanks.
And it's so exciting when you see it happen. So we have the braided funding streams brought together. We have 23 assertive community treatment teams in Maricopa County alone. We have 3 that are focused on justice-involved individuals. And so when you look at the value-based stream, they measure sort of traditional measures like hospital inpatient, ED utilization, but they also measure homelessness, they measure justice involvement, and the decreases that we've seen, 76% reduction in justice-involved members in those 3 assertive community treatment teams that focus on justice-involved individuals. By braiding the funding streams, aligning the incentives, and creating value-based arrangements, it's so powerful, and it is the future, and it is the opportunity really by creating these braided funding stream structures and working with the delivery system in terms of where the future is going.
Florence mentioned some payment models that we have been looking at in the recent past, such as accountable care organizations. Are models like that the answer, or do we need different models?
I think that's a big question, obviously. I think the fundamental barrier, again, is fee-for-service, right? So many of these structures are well aligned and well intended, but the engines on which they turn are still largely volume based. So I think, pushing ahead from the concept to deeper reform, more accountability for total cost at both the plan and the provider level. But beyond that, then, there's also a limitation in terms of payment models with respect to the types of activities that can be counted or reflected in financing arrangements. So many high-impact behavioral and social interventions can't be reflected in an encounter that can be reported somewhere, but do have a tremendous impact on capacity and cost. And so part of that reform, I think, is looking at, again, our traditional system of counting encounters to measure what we pay for, as opposed to counting outcomes. And the most exciting and impactful alternative payment models will create financing arrangements for social determinant interventions, community-based interventions, housing, well outside the scope of healthcare.
Yep.
That's where we need to push.
And maybe I would highlight as an example of that, the Medicaid and Medicare's Innovation Center Accountable Health Communities pilots that are taking place now, where they funded scores of healthcare systems to do screening of the patients, not just for behavioral health, but also for social and economic issues that insurance will never pay for. But what those systems, what that model pays for is someone to not only identify the needs of the patients, but then convene the community organizations, the schools, the other groups that need to be at the table to talk about how those issues can be addressed. So, because sometimes a patient may have, a key to the patient's recovery may be a stable house that they can live in, or it may be working in a coordinated way with the school system so that there's special arrangements that are made. And the clinical providers can't solve all those problems. They can identify the need, but then there has to be a forum that brings together the other sectors as well. And insurance can pay for creating that forum.
Okay, we have a question right here, and then we'll come here. So here first.
Thank you, Stacy Burgess, Veterans Vision. I had two questions. One with the suicide. We've got 22 veterans actually that commit suicide every day, and one soldier every day that commits suicide. And we're off-labeling antipsychotic drugs, aka schizophrenic drugs. And most of our veterans get multiples of these drugs, as well as kids in school are getting Schedule II narcotics, be it Adderall or Ritalin. These are Schedule II narcotics and very deadly, dangerous drugs. What are the side effects of giving these kids these narcotics at a young age as far as the long-term side effects? And what association do you have with these antipsychotic drugs and the 25% increase in suicides when these drugs, disclaimers say that these drugs cause suicides, heart attacks, strokes, and sudden death? Are there any ties to that increase in suicide and the flood of antipsychotic drugs to the public?
It's a hard one.
Yeah, so the one thing I'll mention is, there was a GAO, I believe it was a GAO study that looked specifically at kids in foster care and out-of-home placements and the high use of antipsychotics within that population. And so I know at least in Arizona, and I think in many states, there's been concerted efforts to work with providers, to work with payers to reduce the overall use. Specifically for that population. So that's one subset of the question that you asked, but there's clearly initiatives within the Medicaid side in many of the states to look at the foster care out-of-home placement population.
And I would just add that the use of any kind of mental health medication carries with it significant risks. They shouldn't be used lightly. We've seen over-prescribing of antipsychotics with an elderly population. And fortunately, there's some very effective initiatives going on to reduce that. But at the same time, I want to caution that the appropriate use of drugs like Adderall, the Schedule II for children with ADHD, the antipsychotics, the antidepressants are actually life-saving for some people. So I don't think it's an either or, it's a both and how do we exercise the appropriate controls and allow people to get access to what they need, because some people's lives are literally saved because of these medications.
Right.
So we have a follow-up question right here.
I have, actually, my question was
Hold on, the
similar to-
microphone is coming. Here it is behind you.
It was less about the appropriate use and more about what you see as the barriers and the opportunities to a medication record that would enable, along that continuum of care, access to the information that could be useful to liberate whatever appropriate medication use would be. So, I mean, it's a follow-up from that in terms of recognizing what the issue and the problem is, but in what way, you talked about shared data and ensuring that you have access to that data, and I know there's a lot of school-based medication use and across the system, so what barriers or opportunities do you see?
Could you identify yourself, please?
Katie Capps with Health 2 Resources. So opportunities for appropriate medication use when you have a more integrated medical record or whatever the case may be.
Well, it's not only within the integrated medical record, it's also information that aggregates up to the plan level as well, because when you have a carve-out and you have two separate payers involved, that information is rarely shared. And so the payers don't have good information in which to assist providers with care coordination as well. So part of the strategy in terms of integration is also integrating at the payer level so that that data can be aggregated in a manner such that providers across the continuum of services have better access to information.
And where that has occurred so recently, that part of the carve-out in our state, in Colorado, was ended, at least in part of the state. And so being able to see all of that data, to identify harmful interactions, to identify unexplained variation in prescribing patterns, to communicate and coordinate with prescribers is a big part of the problem, or a big part of the opportunity. And I think that again, the carve-out and some of the legacy funding and financing arrangements have contributed to adverse outcomes, and also a lot of trial error, hit and miss with respect to drugs. Also missed opportunity with promising new technologies like injectables.
And I would add, we have so many people with serious mental health conditions who end up in our criminal justice and juvenile justice systems. And those systems are paid differently, often have very limited access to medications, and we see people switched. So that lack of continuity is significantly impacting people's abilities to recover and live good lives. We also see that even within the difference between hospital systems and community mental health systems. So people will stop taking a medication, end up being hospitalized, get put on something entirely different, and there's a disconnect between what will work for somebody long-term in the community versus what is used in the hospital system in the short term.
And I think also this is really where the integration of service, where there's knowledge across the clinical providers makes a difference, because sometimes drugs that are being taken for physical conditions are contraindicated for if you're taking a drug for a mental health condition. Sometimes you may want to change your diet or counsel someone on sleeping. I mean, there's a number of different approaches that if you had a multidisciplinary team talking that through and considering how to improve the quality of life of the individual would make a difference. I mean, my own experience was for many years, I think this is changing now, the notion was only address one thing. Like particularly in terms of the mental health system, it was just focus on that. If the person smokes, if the person has high blood pressure, if the person has other problems, just focus on controlling their mental health symptoms, which actually became very harmful for the person. The person wasn't treated as a full person that had a lot of different concerns, and sometimes that would result in the patient not wanting to take their medications or dying at a younger age unnecessarily. So really thinking about those clinical, a multidisciplinary team approach to medication and promotion of health is wise.
Okay, we have a question in the back.
Yeah, hi. Thank you. This is rather heartening at a certain level in terms of the reaching out to broader social and economic sectors and helping the individual. Who am I? I'm Dr. Mindy Reiser. I worked for HRSA and SAMHSA and was one of the people behind the National Practitioner Data Bank. Some of you may recognize that. That was Henry Waxman's initiative a number of years ago. My question is this. We're certainly focusing rightly on the individual with challenges, but of course he or she, if it's a younger person, has parents. And then we get into the issues of lack of work, poor housing. So one needs to reach not just the person, but his immediate circle and maybe even beyond, which gets us into the larger macro question, which Senator Minneke would have certainly resonated with. What are we doing when we have an administration that's wanting to cut a great deal of the funding for the initiatives that we're talking about? That ramifies to the state level. So our impetus, our advocacy has to go to funding overall, because if we're going to integrate some of the work of HUD, which certainly needs to do some good work these days, and that's really not happening very much. And if we're talking about workforce development, we're talking about economic opportunities, the money needs to be there. The impetus in certain circles of this country now is to shrivel that. So I'd like some comments on this.
Well, of course, in this country we spend much more on healthcare than we do on human services, social programs, and I think part of what we see in our outcomes as a nation is reflective of that fact. I don't pretend to have any insight into how to solve federal issues, but I do think there is tremendous power at the community level and certainly at the state level, and states can make a huge difference. Again, by integrating their own programs, by using state dollars. Again, I think Arizona is a model in that regard. And so, yes, these are big ticket issues and federal policy matters, but we don't have to wait. We can start in our own communities. We can certainly start at the state level to achieve better integration and wiser use of public resources to address social determinants of health.
I mean, for me, what's exciting about this is you've seen this fundamental transformation occur within the Medicaid program, and particularly for states that leverage managed care like Arizona, to really a broader focus on social determinants of health and other things like that. So you have for-profit plans actually looking at types of solutions in Arizona where they've taken money that normally would have to sit on our books as equity reserve and wanting to invest that in housing. So I think to a certain extent it requires creativity at the local and state level, because one of the wonderful dynamics about Medicaid is the state has some level of operational control of that program and how you want to structure it and how you want to work with local community providers and families and members and look to address issues around integration. So I'm excited about the future and where it's going in terms of just looking at opportunities to be creative and leverage a variety of different funding streams.
I would say I think the federal agencies are underfunded to deal with these issues, and therefore their hands often are tied in terms of meeting the actual needs of communities. Pilot programs get funded, but then when lessons are learned, they don't get scaled. And so definitely federal agencies need the resources in order to be able to address these issues. I would also say at a federal policy level, high quality insurance coverage for as many people as possible is key. And the efforts, I think now, we've seen proposals and policies that allow for insurance coverage that may not cover mental health or substance abuse services, or may cover a portion of it but not be comprehensive. So I would say we really need federal policy that maximizes the coverage of people with high quality insurance, so that some of these model programs in Medicaid, for example, that we're talking about, are not limited to a small segment of the population, but that are as available as widely as possible.
Okay, we still one question right here.
Hi, I'm April Joy Damien. I'm at the National Quality Forum as well as in the Department of Mental Health at Johns Hopkins School of Public Health. So I actually have two questions. You can feel free to answer either one. So my first question is around shared decision making and understand. We've talked a lot about what providers and their responsibility, and I feel like we throw so much at providers, but understanding how can systems and policies better support patient engagement in understanding their preferences, their values, as well as caregivers. And sometimes, I know this as both a researcher and as well as a caregiver, that sometimes patients themselves will not seek mental health services, and once they do, they might not stay in those services. And then the second question is understanding what would it take for a paradigm shift towards more strength-based approaches and understanding mental health, since a lot of the focus has been on deficits and addressing depression, schizophrenia, but my real interest is in building resiliency and trauma-informed care. And it seems that there's not a lot of policies or systems that support those approaches. I know there's trauma-informed care in schools in Maryland, for example, but really understanding how can we scale that up so that it's not just focused on what's wrong with this patient, but how is it more of like, how can we leverage their strengths, the strengths of their family and their community? Thanks.
So go ahead.
Okay. Well, sorry, I can't help. You said NQF, so I was activated. So we need better measures, right? But there are huge opportunities, and we know that the engagement of an individual, the activation of an individual, sometimes just starts with a simple conversation. So in our work, we have heavily promoted the patient activation measure. And to the credit of our state, they've recognized that in incentive systems. We've diffused that through our provider base and are beginning to get longitudinal data that's incredibly powerful with respect to how people are engaged in their own health and can begin to understand the relationship between some of their goals, their choices, and their opportunities. The other area I would focus on has to do with the accountable health communities model. So we're working on one of those in our programs as well. The very act of asking somebody whether or not they're hungry or whether or not they feel safe when they go home can be incredibly powerful. I think the challenge in clinical settings is that when you think of it as a screening process, you screen for a risk and then there's a tendency to desire to want to do something about it. Sometimes there's not a lot to do about it, but the act of asking is incredibly powerful. And so I would encourage the development of those types of engagement and measurement programs because, again, they start the process of activation within an individual. We can measure it, and there's evidence that it's predictive and powerful.
So the last several years have been such a great learning opportunity for our organization, myself personally, as we've gone through this integration journey. One of the important lessons for me was just the power of peer services in all of this and actually extending the opportunity to support providers and allowing for a level of connection that oftentimes might not exist without the work of peers in a variety of different settings. And so, I think we just need to continue to look to be creative, and Medicaid, I think, has been a leader in this area in many states in terms of trying to leverage peer support services, family support services, and other things like that to help support providers and the member.
I just want to add, and I'm glad you brought up peer support services. I think they're indispensable. There are also clinicians out there that simply ask the question, like you mentioned, Patrick. For my son, for example, when he recently had a psychotic break, he did not go to a hospital because he said, I'm psychotic and I need help. He went to a hospital because a great clinician said, it sounds like you're not sleeping well and that's bothering you, right? Yes, I want to sleep. And my head hurts. Yes, we can help you with that. And he was able to go to a hospital because his head hurt and he couldn't sleep, not because he was going to admit that he was psychotic. Right? So we need systems that incentivize people to really ask those questions. But the irony here is we have systems that are set up that the criteria for being admitted to a hospital is dangerousness to self or others. So until we start fixing some of those dichotomies, we don't get to a place where we're really focusing on what's meaningful to the individual. What goals do they have in life? Why do they want to seek care? Instead, we make it as hard as humanly possible, and we have to bridge things that don't bridge easily.
Okay, do you have a question? Okay, this is our last question, and then we're going to wrap up. It's coming.
I'll be good. Hi, I'm Doug Tynan from the American Psychological Association, the Office of Integrated Care. And in my work with the Delaware State Health Innovation, we discovered that even though the perception was that all the family practice was provided by one system, Christiana Care, we found hundreds of family practice providers in solo and 2-provider practices. Then we also discovered hundreds of mental health providers in solo and 2-provider practices. So while we've discussed large systems, my question is, how do we create incentives for these small businesses, which is what private practices are, to make this a viable business model, to make integrated care a viable business model for the small practices? Because the guilds, family practice, internal medicine, psychology, psychiatry, focus on their professionals only. They don't work together. So that's my question. How do we, for all the, particularly those rural, far-out communities, where we often have small practices, how do we make integrated care a viable business model?
Really quickly, I would just say we should not assume that it can't work in those settings. In our experience, it has, again, with appropriate payment support. Some of our best performing provider groups are our smallest provider groups. And again, so for what it's worth, in system design, coming up with a system that doesn't just assume you need a massive, heavily capitalized ACO to do anything, or any other, a big FQHC system, whatever it is, but a set of criteria that can work across all of those settings and draw objective conclusions and make objective investments. Again, it can work in small settings.
But where you can leverage opportunities to spread fixed costs too, whether it's all the back office functions or looking at trying to spread the cost of electronic health records and other things like that across at least groups of smaller providers, I think.
Care teams.
Yeah, trying to leverage those fixed costs over a broader purchasing power rather than just a single individual practice.
Okay, we're going to stop there. Please join me in thanking our panelists for a very thoughtful discussion. And thanks for coming out today. We know it's August, and hope you've had some vacation this month, but thanks for coming out today.